Good afternoon to all our attendees. I want to welcome you to this webinar, IFSO EC webinar, an introduction to robotic bariatric surgery, useful basics you need to know before you start. It's almost a Christmas webinar, and I'm very glad we have a very prominent faculty, and I maybe hand over immediately to Juan Santiago Azagre, who will chair the whole thing together with me. We are the two moderators. My name is Gerhard Prager, former IFSO president. And Juan, please go ahead.
Okay, good afternoon, everyone from Luxembourg. My name is Juan Santiago Azagra. I am surgeon in the Centre Hospitalier of Luxembourg. And it is a real great satisfaction that I share this moderation with Professor Gerhard Prager as part in this fantastic seminar, because it's dedicated to how to get started with robotic bariatric surgery. In my humble opinion, as far as I'm concerned, this seminar has come at an opportune moment, because it's not a secret for nobody. Today in United States, more than 40% of all bariatric surgery are performed with robots. And in France, in the last year, 30% of the gastric bypasses are performed with the robots too. Well, it's maybe very useful to change a little bit the title of the webinar. And I propose this one: teaching robotic bariatric surgery for the new generation is maybe the next challenge. It's not totally realistic, because it's not for the next challenge, is the actual challenge. Is the actual challenge, my friend, because surgery, like reading and writing, is not epigenetic. It's necessary to learn it in order to have this one in your hands. And it is really true, of course, for the bariatric surgery. For that, it is mandatory to establish probably a framework in order to do that with a responsible manner. How to change is very important to define before, because tend to establish bariatric surgery, particularly with robot in one hospital, is just into the frame of the real project. Second one, because you are what we do, how we do it, why we do it, etc. This type of situation requires conceptualization of surgery, and this manner to do in order to implement force us to structure a service project. And it's very important differentiating ourselves from laparoscopy by finding added value. And for that, this is require the control of results. Everything starts by the perfect purchase. Not easy to do. The mutualization of the robot is not, in my opinion, an ideal solution, because the efficient and safe use of the robots for you in the future depends fundamentally on learning how to use them. It is necessary to start robot and to make robot several times per week. And after that, design a real implementation in order to obtain the reality of your work and go to the cost benefit. Here, our manner to implement robotic. The tool is bariatric surgery. Bariatric surgery, because bariatric surgery is very frequent, is very standardized surgery, is a real model, step by step. And with this manner, we have two targets in the same time. Your resident have in your hands not only bariatric surgery, but bariatric surgery and robotic surgery too. This is the fantastic manner to go to the cost effectiveness, of course. And in order to classify your results, of course, prospective randomized studies are very important, but now work under the frame of utility concept is very useful too, because it's very easy to compare your work with the robots with your work with the laparoscopic surgery, or showing the simplicity of your manner to do, realizing the real benchmarking similar or better with laparoscopy, and defining with the clarifying manner the implementation of this. Systematization is the key of this surgery, believe me. And in bariatric surgery with the robot, systematizations is very easy to obtain. After conceptualizing this surgery, it's mandatory, in my humble opinion, go to the real robotic surgery and no robotic assisted surgery. This manner to do introduce the notion of the solo surgery. And for me, the solo surgery in robotics is maximize coordination, many minds by just one hand is the best manner, in my opinion, to do this type of surgery. Thank you. And the web seminar start, of course, now. Thank you, Prager.
Gerard, you are mute.
Sorry for that. I want to introduce the faculty to you. We have two speakers. The first one will be Carlos Vaz from Lisbon in Portugal. He's Director of Obesity and Metabolic Surgery Unit and Director of Robotic Surgery Unit. Then we will have our second talk by Professor Marco Raffaeli. He's a professor of surgery, head of the Division of Endocrine and Metabolic Surgery at Gemelli Clinic. He needs no further introduction, I believe, and we have two fantastic debaters. First one is Miljana Vladimirov. She is the head in Germany of the metabolic surgery at University Bielefeld campus Lippe-Detmold. And then we have a real titan of metabolic bariatric surgery, Jacques Himpens, who has performed the first robotic surgery in the world in 1997. He's a former IFSO world president, and I visited him the first time in 2001, and it was always a pleasure to watch him doing metabolic bariatric surgery. So you see a very dedicated faculty, and we go immediately to the first talk that is recorded and will be given by Carlos Vaz.
Hello, good afternoon. I am very grateful to the IFSO European chapter and to my good friend Juan Puyol for the invitation to this webinar. It's a big pleasure and a big honor to be here. It's also a big pleasure to be on the same webinar as my surgical father that I don't see for a while, which is Professor Jacques Himpens. Hello, Jacques. I'm very happy to see you again here. So today I will do a small talk, and I will keep on the very basics, as I have been told to speak on the different components of the robotic platform, but for beginners. So we will keep it very basic, and I will try to speak a little bit of what is my experience with those different components of the robotic platform. Actually, when we talk about the robotic platform, we have now several platforms on the market, which is good because the monopoly is finishing. Mainly in Europe, we have already three, which is the Intuitive, the first one, and more recently we have the Medtronic Hugo robotic assisted surgery system and the Vertis from CMR. Actually, there are a few more coming, mainly from China and from Japan, also some from Europe. From China, they are very advanced, I must say, but we are not going to talk about those platforms as they are not in the market yet. Also on Intuitive, I will speak you about the platforms I know. They have already the DaVinci 5, but I don't have any experience with that new platform, and we have almost none of those platforms in Europe. Most of all, I will talk to you on the DaVinci X and XI, a little bit on SP, and then much faster we will go for through the Medtronic and CMR platforms. But as I'm telling you, we will take most of the time with the most used platform all over the world and in Europe, which is the DaVinci X and XI. So starting with the DaVinci platform, we have the patient card and the vision card and the surgeon console. We have to say that the surgeon console and the vision card are common to DaVinci X, DaVinci XI, and to DaVinci SP for single port surgery. Also, more recently, they launched the My Intuitive application, which is a very nice application where you can record everything you do, and they give you a lot of statistics that are very helpful for you to advance and to check where you can improve your surgical performance. So it's a very, very useful tool. I must say that this kind of tool, this kind of applications are common. Also, Medtronic has one, and CMR also. So there is no difference on the application, but all the three platforms they have these applications that they make your life much easier on recording your operations and learning from them. Starting with the vision card. So the vision card includes the support for electronic equipment such as the light source and the video processor. It's no more than a tower where you have the screen. It's a touch screen where you can adjust all the system, and it's on the bedside of the patient. You have the endoscopic controller and the video processor that you see here. So this is the endoscopic controller, and this is the video processor here. Then you have some shelves for example, the insufflator or whatever. Then you have the supply for energy instruments, which is from Erbe. It's a joint venture between the Intuitive and the Erbe company. And then you have behind the tank support when you don't have your CO2 coming from the building, you can just put your tank of CO2 behind. And most important of all, the central processing unit, which is the brain of the system, where the main software is. It's this area on the bottom of your tower here. Here on the shelves, when you use the insufflator, normally we like to use the air seal system, but you can put any insufflator there, and that's fine. Then you have the surgeon console. And now here we need a little bit more time to explain all what you have on the surgeon console. So you have the screen, and the screen is here. It's a binocular screen, and you have an immersive view. There is a discussion whether this immersive view, which gives you the sensation that you are inside the patient, whether this is good or bad. I like it, I must say, but some surgeons say that they don't see the room so well, and they are too much inside of the patient, and they lose a little bit control of the OR. For me, this is not a problem. I like to feel inside of the patient. I think I see better, but there is a discussion on that. Then you have some the ergonomic adjustments where you can lift the place where you put your head, or the place where you put your arms, or the pedals area. You have the forearm support. The forearm support, it's a very important feature that you can have your forearms supported, and that's in my nobody talks about it, but it's in my view one big advantage from laparoscopy is that when you have your forearms supported, you can be much more precise with whatever you do. There is a break for the console here on this area. You see the four, all the pedals. We will go through the pedals on the next slide. Then you have the instrument controls or the joysticks. Here you have the buttons on off and the emergency button. And here you have a touch screen interface. So if we go a little bit further on these features of the console, you have here the joystick. It's the most simple and the most, I think, genial joystick of all platforms in the market. It's very, very simple. You just put your fingers here on these holes. You can put your first two fingers, or you can put the first and the third finger, and you keep the second finger to use here. Here, this is a clutch. I will explain you what the clutch is. You can use the second finger for the clutch, but it's a very simple joystick, and there are some guys looked at that, and it seems that you take 1.5 minutes to get used to it because it's so simple and so intuitive. Then you have the pedals. Here you have the camera pedal, and how does it work? So when you use your joystick for the instruments, you just use the joysticks and you move the instruments. But if you touch the camera pedal, then when you move the joysticks, you move the camera. So that's how it works. Here you have the clutch pedal. The clutch is very important, and that's what makes you be always on the best position. Because whenever your arms are going away on the console, you can just put your feet on you can just press the clutch, and then you bring your arms again to the forearm support. You put yourself on a nice position, and you keep working. And this is very, very important, and it's one of the biggest advantages also on my opinion of the robot, is that you are always on the perfect position. And sometimes when you do laparoscopy, you are very non-ergonomic positions doing complex tasks, and that makes your life very difficult. So for suturing, for dissecting, for suturing on the abdominal wall, for example, you can be always on the perfect position, and that's the clutch that allows you that. This is another pedal here, lateral, and with this pedal, you can switch between arms that are active, because you have the camera and you have 3 arms. So it's 4 arms in total, 1 arm for the camera and 3 arms for 3 instruments that you can control. But each time you can only control 2 arms, because you have only 2 joysticks and you have only 2 hands. So you control 2 arms, but you can switch in between either the arms on the right side of the camera or the arms on the left side of the camera. And this is the pedal where you can switch in between arms that you are in control. Here you have the touch screen where you can control everything from the console. And here there's a place where you put your head. You see lateral here, you see some sensors. And when you put your head there, if you move the joysticks, you move the instruments. But if you take your head from here, then if you move the joysticks, the instruments are not moving, because the system knows that your head is not on the console, and you are not seeing what you are doing. So that's a security or a safety feature. The energy instruments that you have, it's scissors and the hook for monopolar. You can it's not on this picture, but you can have also bipolar instruments. It can be a Maryland or can be a fenestrated rasper, and then you have the vessel sealer and the synchro seal, which is a kind of ligature from Medtronic, let's say. Then you have a lot of instruments, and very important, all the instruments are wristed, so you can wrist the instruments inside of the patient, and this is another distinctive feature of a robotic surgery that makes your operation much easier. And if you see, there are a lot of instruments, and the intuitive instruments are very well designed and very nice to use. Finally, we have the patient car, and the patient car is what changes in between platforms. So in between the different Da Vinci platforms. So you have the X, which is the entry system, the entry level platform on the intuitive ecosystem. The forearms are rooted on the main vertical spine, and that's the difference to the Da Vinci Xi that you will see next. The spine supports the arms. Then you have the car tractor here, and then you have the base with the electronic components, and here the brake of the patient car. This is maybe the most used platform. It's a Da Vinci Xi, and the patient car from the Da Vinci Xi has the forearms suspended from one boom, and that's the big news, because this boom can rotate it around 180 degrees, so it's easier to dock, and you can change positions. And it allows you multiple anatomical targets during a complex procedure with simple adjustments and no need to redocking. Also in the Da Vinci Xi, you can have integrated table motion, and so the table will move together with the robot. Finally, also you can have either on the Da Vinci X or on the Da Vinci Xi, you can have indocyanine green that allows you to check perfusion of some organs when doing an anastomose, or like you see on this example, you can see the biliary tree in a complex cholecystectomy, for example. Then you have the SP card, and the SP, it's the most advanced minimally invasive platform. It's for single port surgery. You have 3 wristed arms and the camera, and allows you for operations by a single port in small surgical sites. I don't know if there is a big advantage on single port, but maybe some cosmetic advantage for sure. Yeah, it's coming. There is also coming from China. It's called Shurui, a very nice platform for single port. So this was for the Da Vinci. On the Medtronic, we are going much faster. Medtronic, big difference is you have an open console layout. Some people will like it better. You see the console here, and it's an open console. The tower is more or less similar to the intuitive, and then another big difference, it's modular, and you have 4 independently extendable arm cards. You can have 3 arms or 4 arms in the OR as you wish. It's I think the biggest advantage is the pricing is competitive, lower entry cost, and it's the modular system. Maybe in some cases, mainly when you need only 3 arms, easier to dock. When you have 4 arms, I think it's a bit more difficult. But yeah, that's the Medtronic platform. In this platform, you can maybe do your operations on a price that it is closer to the price of laparoscopy. There are still some limitations. They don't have suturing, mechanical suturing, and they don't have still advanced energy like LigaSure on the robotic platform. Finally, the CMR versus again an open console platform, and again a modular platform with each arm on its own base. There are only 6 instruments. It's the smallest modular and portable robotic platform, which has some advantages. It's more flexible. Also some disadvantages. Mainly, it's not too heavy, and so it's not so stable. It's not as stable as the Intuitive or the Medtronic platform. The console, as you see, it's open and you can work standing or sitting down. Another difference is that the joystick, it's much more complex and there are no pedals, so everything is on the hand. I think the manufacturers saw some advantage on that. I see it a little bit complex to the long learning curve, in my opinion, but let's see. So these are the instruments. Again, we have no mechanical suturing and we have no advanced energy on the Versus and also on the Versus, and you have the same on the Medtronic. You have an app where you can record everything, and you can have very, very useful statistics for improving. And that was my, in 15 minutes, a little bit more, what I have to show to you. Thank you very much. Thank you.
Thank you very much, Carlos. This was a fantastic overview and an excellent introduction. We have already some questions in the chat. Please don't hesitate and write your questions into the chat. Carlos, the first question for you is from the chat, from Panagiotis Lainas. Do you have any contraindications for robotic metabolic surgery regarding patient characteristics, which means BMI, weight, left liver lobe size, etc.?
Hello, and thank you for having me here. It's a big pleasure. I would like also to say hello to Jacques. He's a very special person for me, and not because of robotic surgery personally, but also in robotic surgery. He's doing the first robotic operation in the world. So the question was, sorry, I lost.
Do you have any contraindications for robotic surgery regarding?
No, I would say the same, or maybe less, maybe even less than for laparoscopy. I don't have any contraindication. I would say no. I don't see more contraindications than in laparoscopy. Maybe in laparoscopy there are some patients that I wouldn't dare to operate. Big patient with several previous operations, and with the robot I will do it. So I don't see at least more contraindications than for laparoscopy. Maybe a contraindication for the pneumoperitoneum or those general contraindications, but not specific robotic contraindications.
Miliana, Jacques, do you want to comment on that? You're muted, both.
Yeah. I'm sorry.
Yeah,
Go ahead, Miliana.
Hello, Jacques.
In my opinion, there are no contraindication to do metabolic bariatric surgery with a robot. I mean, according to BMI or big liver, you have better visualization, better ergonomics, and in my opinion, if you have a robot, you have less limitations to do this kind of surgery, minimally invasive.
I have several experiences already of converting from laparoscopy to robotics because of that.
Yes, now, in my humble opinion, including alternatives is better, more simple to freeze with robot to compare with laparoscopy. And concerning the very big liver in patients, so for example, the class of 5 patients over 200 kilos with the BMIs over 70. Today, robots permits to obtain the same dissection, but with the other manner to do. For example, the his angle, it is possible to obtain the total dissection just below the stomach in retrogastric position, very comfortable with the robot. Sometimes it's possible to do that by laparoscopy, but it's more difficult. The organomegaly is have the real advantage to be considered with a robotic approach.
Often people claim that ergonomy is one of the biggest advantages of robotics, which means as a surgeon, you are relaxed after the operation, even if it's a very high BMI patient. Do you find this true, or do you have more neck pain when you're in the console?
I find it true. From an ergonomic point of view, it's true that with the current systems, it's not an ideal position for your neck. The next generation, so the Da Vinci 5 solves that problem, because you bring the console to you and you just place yourself wherever you want, which doesn't happen with the consoles that we just talked about. So it will not be a problem anymore. But even with the current consoles, I find it much better than by laparoscopy, because by laparoscopy, sometimes you are in really nasty positions.
We have two further questions from the chat. Maybe Jacques, you can comment on that. The first one is from Ahmed Abu Katsima. What number of cases needed in the learning program before working alone?
A good question, and there's some publications on that. And I think the consensus, but I think Santi will be there to correct me if I'm wrong. Before to have full confidence on the on the system, it's 100 cases, and which is significantly less than in laparoscopy, but it is not like we used to hear in the beginning, 10 or 15 cases. Before you're really acquainted with the whole thing, it should be 100 cases.
Yeah, I think I started 1 year ago, and I think I'm quite skilled laparoscopic surgeon, but I can just confirm what you said. You need to do the whole machine without thinking about anything. I think this is the key point, and this takes some cases. Maybe I think 100 is quite reasonable. Yeah, we have one more question from Taki Mohammed. Would an apparent complicated anatomy be a contraindication for robotic surgery? Carlos.
And well, I think we already answered to that before. I wouldn't say that it's not more than for laparoscopy, yeah, for sure.
You mentioned already that prior operations are no contraindications. You see even an advantage. But if you deal with cases that had several laparotomies, where it's hard to get into the abdomen, then you are, with the robotic approach, quite limited, because you have more or less a fixed area where you place your robotic trocars. Would you like to comment on that? Maybe Miliana? What do you do in these cases that had several laparotomies? I still do laparoscopy on them, but for these cases, I'm still a little bit hesitant to go robotic.
So I tried that case to clean all adhesions and go with the robot, if it's possible. If
but
not,
you cannot get in. You get in with one trocar very lateral.
Normally what I do is I just make the necessary dissection by laparoscopy to place my 4 trocars, and then whenever I have the space for the 4 robotic trocars, then I put the robot immediately, and then I really feel that my life will change on that moment. So I suffer a lot to put my trocars. And then I dock the robot and my life changes. I go to the console and it's not a problem anymore.
Exactly.
Yes, so it's a combination of laparoscopy and then you switch to robotic.
Yes, yeah. Including with the experience, this first step, utilizing the laparoscopic method to the robotic trocars, okay, is limited. Okay, so just in the first cases we have it's not easy, but with not too much cases, with 10 cases with adherences, it is possible to put the robot in the very good locations in order to continue freezing adherences with the robot, and after that do the real intervention. A concern the prior question about what is learning curve is the crucial question, because is the most important is have the tool in your hands. One time you have the robot in your hands, in order, for example, to have the bypass robotic in your hands with 25 cases, in our experience, is good. It's our experience for our residents, 25 patients, and technically, my residents have the opportunity to do one bypass without my personal hand.
In many places all over Europe, there is limited availability of robots. So often in the hospital, people have to share the robot between surgeons, gynecologists, and urologists. So the exposure for a single surgeon is not that often, not several times a week. What would you emphasize or suggest to the surgeons that have not this frequent exposure? Shouldn't they start, or should they start and hope that they pass the learning curve faster?
Yeah, I think they should start and make pressure on the board of the hospital to buy a second platform or a first platform or whatever. But they should start, otherwise they will never do it.
Okay. We have one more question from the chat before we go to our next speaker, because we run a little bit out of time. Mohamed Sidan wants to know, should surgeons in the early learning curve of robotic use conventional laparoscopic trocar sites in fear that they would convert to laparoscopic approach? That's an easy one, I think.
No.
I think not. No.
Because they are much different, and
yeah.
And
very likely they will convert.
Okay.
If they do that.
Well, Miliana, Jacques, from your side, any more comments?
Maybe a question. I don't know if you will be able to answer, Carlos. I think one of the problems with the Da Vinci system is the fact that it's not cordless. And we all remember the Lindbergh operation, where Maresco was in New York and the patient was in Strasbourg. So obviously there was no, there were no fibers or anything linking the two systems. But here, in real life with the Da Vinci, there's still an actual connection between the two. Are there any plans to have some Bluetooth system or something that would get rid of those? And I think those wires are a big problem in the OR, actually.
Yeah, that's true. That's a good question. So yes, there are two technological problems to solve on that. So one is the speed of the connectivity. So we thought that with 5G it will be solved, but it's still not. Maybe with the next generation. But also the technology of the platforms themselves are still not ready for that. Actually, there is now one system coming from China, and it has already the CE approval. I think it's I don't remember the name, but it's CE approved, and it's quite a copy of the Da Vinci 5.
Yes.
It's something between Da Vinci Xi and Da Vinci 5. And they can already perform this surgery at a distance, even with 5G. So I think it will come very soon. It will come very soon.
Yes, as you said, in China there is already the real life. There are several operations performed per day from one hospital to the other.
Yeah, that's true. They are very advanced. We have no idea, but they are very advanced. And they have a single port robot. They call it Shurui, and it's amazing.
And what's so amazing about it?
It's you have also 4 arms like with the SP, but the picture is better, and the range of the arms it's bigger. I don't know how they can do it, but the range of the arms it's much bigger.
I think that's yeah. I'm sorry. I think that's one of the shortcomings of the system. In my limited experience, it is that the reachability of the operative field is still quite limited, and it's blocked. And you have to unlock the system to be able to change operative fields. So that I think that's if you can improve or enlarge that operative field, that would be a big step.
That's what this one it's on the way to do.
Thank you.
Sorry, I think we stop here. We have then further time after the second talk to make the remnant questions. Marco, it's my pleasure to announce you. Please give us your talk.
Thank you, Gerard. Thank you, everybody. Thank you to IFSO for inviting me to this excellent webinar. I have the responsibility to talk about the skills that we should reach before the first human procedures. This is my financial disclosure. I have also non-financial disclosure. I did not follow a structured training pathway before performing first robotic procedures. You know, I went for a week in one hospital in Nancy. I learned from a friend. I went back home and I performed my first 3 robotic procedures without any structured training. So this is my disclosure. Which are the skills to be reached? First are technical skills, including assisting, port access, console control, use camera, tie knots, surgery, etc., and non-technical skills. That means theoretical knowledge, team working, communication, decision-making, and above all, from my point of view, troubleshooting the case. There was, since many years, the need of a standardized training curriculum for all those people who are approaching the robotic. They have become more and more in the future. And also, there is a need. We have to answer this need, and we have to set up a minimum curriculum to be reached before starting a non-live procedure. And the steps of such a curriculum are an initial learning, which is what Carlos has already shown us, how the machine works, a simulation training, which can involve dry lab, virtual reality, wet lab, and training in the operating theater with no patient, and then proctoring for the first procedure, and then some back and head for every single procedure, discussing with the proctor. And this need was already underlined last year in this new publication. And again, the steps for a pre-procedural core robotic surgery curriculum, also from the point of view of the trainees, are e-learning, the training on the devices, and simulation. Which should be the components of such curriculum? Virtual simulation, training, and learning, starting from a baseline evaluation of the competence of the trainees, training on the device, and dry lab training. The learning should include the description of hardware in various systems, as Carlos did, info on patient selection, preparation, info on troubleshooting, and how to dock and de-dock the patient. Technical core robotic skills are the use of two-hand movements with hand-raised systems, camera changes, Professor Ibsen's underlined just now, basic movements, tissue dissection, and no tying. Non-technical skill, which of us most important also for, even if they are sometimes forgotten, is the situation awareness, training, how we can face different situations during robotic surgery, is the training of the operative team, is communication between members of the team, and how to face emergency scenarios. And this also the whole operative team should be trained on docking, emergency scenarios, and bedside assistance. With respect to the simulation system, as I told you, there are cadaver labs, animal models, dry lab, and computed system. However, cadaver labs and animal models poses some ethical and legal issues, and they are used less and less frequently. Thank you also to development of very highly performant computed system, which included virtual reality. Indeed, if we look at the how in training in robotic assisted surgery developed, in most of the cases, it through the dry lab system and also the view trainer, which have been developed by different companies, as I try to show you. Is there any difference among these different systems to be trained? It seems that virtual reality is more effective than what I did. That means no training at all, but is similar to the dry lab. It could seem that it less complete with respect to training on cadaver models, on animal models, but very few studies focus it on that. Is there any difference in achieving competence in different age? For sure, yes. Young people are more prone to get higher score in achieving competence, and that's the reason why we should train residents in the very early stage of their residency programs. Does the actual use of smartphones, tablet, etc., make a difference with respect? It doesn't seem so, but typing on smartphone is some way associated with better results in terms of on simulator. What about the other aspect, the non-technical skills? There are very few tools to assess non-technical skills. Indeed, they are sometimes neglected. There is very few studies focusing on non-technical skills, but at least from my point of view, non-technical skills would again represent the way the surgical team collaborate, how we can manage communication, how can we manage troubleshoot, etc., is of utmost importance, and we should work more when training people on this particular aspect. And if we look at the different figure of the surgical team, including the first surgeon, the bedside assistants, the advanced bedside assistant, the surgical technologists, and the circulating nurse, some differences have been individuated. But if you look well, for both technical and non-technical skills, the skills that the bedside assistant, but also the circulating nurse are so very high to reach adequate competence on the robotic platforms. There is a way to facilitate communication in between the bedside assistant and the surgeon. The console, you know, it is not so easy to combine the needs of the surgeon at the console with those of the bedside assistant, which is not seeing the same thing, which are seeing looking the surgeon at the console. The quality of the image is different from the console to the screen at the bed. Some trainer have been developed and also approved in the market, and it seems that they could give good results in terms of collaboration in between the consult surgeon and the bedside assistant. Then if we look at the three platforms that we have at the Gemelli Hospital, and are the same platform Carlos has already discussed, all of the companies has its own training protocol, but they are very similar. They follow the same pathway: learning, training of the team, and simulator. The simulator is one of the most important things that give the trainee the possibility to reach the minimal general skill we need for starting a robotic program.
All-inclusive Da Vinci simulation
In this
and learning
video
program.
is
Sim now provides you the true Da Vinci experience.
the first one
Let's
which
explore
was
the
proposed,
program.
the
Sim now consists
Sim
of
now,
skills,
which
procedures,
is
and
the
links.
simulator of the Da Vinci
Skills.
system,
The
but
skills
also the
section
other
is a
companies have
constantly
similar
expanding library
simulator.
of simulation exercises, all optimized for surgeons.
Some
and any learning
exercises can be
Over
combined,
30 of the
different
latest comprehensive
tasks
core learning
for the
exercises are
surgeon
available, including
at the
instrument
console,
playground,
but also for the
FRS,
bedded
and the
system. It is
combination
very
exercises.
important to train
First, our instrument playground enables you to virtually
train
experience up to 12 different
residents
instruments.
and fellows
You
in
can
the very
deploy
early
and
stage
exchange
of
any
their
instruments you like. Second, our FW1 with either a guided VR procedure or go to freehand versions with no
or
guidance
their
at all.
training programs.
Link.
There is also
Link provides remote
a
access to
simulation
all
hub,
performance
which
metrics
is
that are recorded on the simulator.
give you the opportunity
scores
to
and improve your
choose
skills.
among different procedures and
Access
to
your
score
simulation
which
scores
are
in
the
real time.
results you can reach. It is very important
All
for training. But the same system is also present for Medtronic with the same pre-work, technical training, procedural experience lab, using a technical training pathway for all the team, but also for every single procedure. So computer-based training, simulator, remote coaching, is the same also for CMR with the virtual learning trainer, with an optional virtual reality system, practical training close to the hospital dry run, and then you can start with your robotic program. This is a typical case of a patient, of a case observation in my hospital. As you can see, there is a beginning looking at me while performing room-wide gastric bypass procedures. Then the same beginner was proctored using wet lab animal model before starting, and then for the first surgical procedures was proctored again with some of us looking at its performance. And for every single procedure, we should also have a simulation curriculum that was established several years ago by my friends Laurent Bruno in Nancy, but that all the companies have now in their user guide for every single procedures. But above the company organized training, there are also additional training, general and also specific in different settings that are open to medical students, early career doctors, or all those who would like to start with the program but are not yet in the list of the company because of different reasons. One of them is the lack of a robot in their own hospital. And we know that this kind of course, both basic course, but also specific course, are very useful to achieve some competence. and more specific course like that one, which was organized by Miliana last November in Frankfurt, or that Michel Wiss organized last week in Strasbourg, are extremely important to achieve competence, both from a generic point of view, but also for those who are involved in bariatric surgery or another field of surgery for a specific curriculum. Thank you for your attention and for giving me the privilege of being here.
Thank you very much, Marco, for that excellent lecture. I'm sure we have several questions. Maybe the first one from Alex Gandash in the chat. How do you overcome the inconsistency of credentialing processes, knowing that the lack of quality metrics can jeopardize program success?
Can I read the question?
I think you see it yourself in the chat. It's maybe easier.
Yeah.
How do you overcome the inconsistency of credentialing processes, knowing that the lack of quality metrics can jeopardize program success?
You know, we need to work on that for sure. The quality metrics of the simulator is different from that of we can reach in an animal model, a cadaver model, but probably cadaver model should be leave for those initial procedures. Then having a proctor, having a tutor during the first procedures can help you to achieve the best results or in the clinical settings. It's concerning the metrics of the simulator. If I well understood, we have to work on that. Probably with the new generation of simulators and also with the artificial intelligence, we'll be able to overcome these limitations. This is my point of view, but we need numbers, and we are just at the beginning of this history.
Thank you very much.
I would say also that metrics, it's a big problem on surgical teaching, whatever, open, laparoscopy. It's very difficult to have nice metrics. Now on the simulator, sometimes you have really mathematic metrics on some skills, on some very simple, but to have a metric on the whole operation metrics on the competency during the performance of the Roux-en-Y gastric bypass, I don't think we have it, and I feel it's difficult to have it.
There are a few publications on how training, reaching certain metrics can help you in performing some gastrojejunostomy during Roux-en-Y gastric bypass procedures. So, but again, we need segmentation of the video, and then on that in the future, thanks to the artificial intelligence, probably we'll be able to give a more reliable metrics. But again, as you told, it's difficult metrics in surgery.
May I add something?
Please, go ahead.
I think to ensure the development of competent robotic surgeons, the training programs must incorporate those competency-based assessments. And there's a publication on CAR scale. This scale, CAR scale, reliably differentiates robotic surgery skills across training levels, beginner, intermediate, and advanced. And if you read this publication, specific tasks such as robot docking or tissue dissection tend to be mastered earlier, while complex skills like stapler use required additional focus. So I think the scale highlights critical time points where tailoring tailored training interventions can significantly improve performance. So I think standardized implementation and competency-based evaluation, like CARS, which is published already, are essential for developing and validating robotic skills. I think we need not only the simulation, but also assessment to validate that skills.
Let me tell you something, what you just said, Milian. Just to show how this can be subjective. You just said on the beginning that you talked about simple or very easy tasks like dissection and complex tasks like mechanical suturing. And for example, in my experience, difficult dissection is the most difficult thing. It's much more difficult than hand suturing or than so dissection in a difficult patient, low rectal cancer or bariatric patient with a lot of procedures before. So dissection, and it's difficult to train dissection. It's easy to train suturing because you can train suturing everywhere. But to train dissection, it's very difficult. So, for example, for me, dissection, it's a much more difficult task than hand suturing or mechanical suturing.
Probably, and suturing is much more intuitive with respect to dissection. I agree with you.
And you can train it. It's difficult to train dissection, except in the patients.
May I ask a question because that raised hand doesn't work? Do you think that a poor laparoscopic surgeon can become a good robotic surgeon?
No.
In my opinion, no. I
Okay.
respond by chat, but in my opinion, absolutely not. A concerning simulation.
I agree.
For the moment, we live the very incredible moment because Jacques started robotics in humans in 1997. 1997 is incredible. And now, many people do surgery with robot, but without consider the reality of the normal and organized progress. For example, today we are starting to the sensibilization to utilize simply the devices procuring the simulator, for example. Okay, I have the real difficulties to convince my residents to come into the operative room during the night in order to take simulator. It's incredible. This is the general problem of surgeons, in my humble opinion. Second one, for example, about simulation is very, very, very interesting, in my opinion, okay? With the different members of the team, nurses, anesthesiologists, etc., do the simulation, for example, of the dramatic necessity to convert a robot to the laparotomy, because it's mandatory to know the robot very good in order to avoid the real disaster. Do you retrieve every arm of the robot and you don't have any control about nothing? You guard one arm into the abdomen and you have many possibilities robotics. It is possible to do one laparotomy without dramatic situation. Etc. It's incredible.
These are the non-technical skills that are sometimes under-evaluated, are considered from my point of view, because those who would like to approach the robot platform would like to start and operate with the robot. But we have to know how we can manage troubleshooting. This is very important. Big issues like bleeding, all the team should be trained on that. You are right.
I have a question for both speakers. Let's take the example of robotic gastric bypass. Is the fact of doing this robotically, has it changed the strategy of your technique? Because when I see people doing a robotic gastric bypass, it's exactly the same as laparoscopy. And I don't think most people take sufficient advantage of the capabilities of the robot. Did you yourself and your practice, has your technique changed sensibly?
From my point of view, first I would like to answer the previous question. Is one non-good laparoscopic surgeon can become a good robotic surgeon? I don't think so, but I think it could be easier to become a good robotic surgeon with respect to become a good laparoscopic surgeon. So robotic is more democratic than laparoscopy, at least from my point of view. For the question, it changed a little bit. You know, you can work with a lower insufflation pressure. In most of the cases, you can perform angio anastomosis if needed, or even if not needed. So there are dissection in some cases is much easier. I feel that robotic is an added value for bariatric surgery.
Could you imagine
So
a
if
procedure without any staples?
Yes, I did. It's possible. It's faster, at least performing the pouch with the stapler than perform both anastomosis and soon. It happens more than
so,
we can.
so the main difference in my practice from laparoscopy to robotics, it's just that I perform my gastrojejunal anastomose always hand-sewn. You remember, Jacques, that for 2 years we did that in Dendermonde. When Kelvin started doing it hand-sewn, then we did two complete years hand-sewn, but then we came back to the stapler because it took a little bit longer. But we were very happy with the results because we had almost no leaks. Maybe I don't remember it very well, but I think the results were very good. But we just changed back because it took a little bit longer. But with the robot, you can do the hand-sewn anastomose at the same time. And I feel, I can't prove it, but I feel that I have less leaks. I have no leaks actually since 2010 in primary cases. So I have one or two leaks in revision cases, but no one leak in primary cases, no one clinical leak. So that's the main. Also, the thing is, I see a big advantage when I do revision surgery. But if I don't do my primary cases, and if I would do only my revision cases, then I wouldn't have the experience to go for more complex cases. So that's my point of view on that.
There is also another point. What Santi was saying at the beginning, we are shifting towards solo surgery. At the beginning, it was considered that we need one trocar more in robotic bariatric, but what I feel now is we have at least one trocar less with respect to the laparoscopy.
Yes, Marco, but I come back about your thinking about the possibilities offered with the robot in order to facilitate the surgical gestual. I agree totally with you. We are all together laparoscopists since many years. We are pioneers. We are very enthusiastic during many years because more is less, because it's better and better and better. But 40 years later, personally, I consider I know the limits of laparoscopy, particularly in the interventions qualified with the very high complexity. And the problem is the team. The problem is two brains working together with 4 hands. This is the drama of laparoscopy, in my clear opinion, particularly in the teaching hospital, because I change of assistants every year. I work during my life with the young people. Robots this type of situations disappear totally. For that, I invite the surgeons to conceptualize surgery, to do the real robotic surgery, because with this manner, and in order to do bariatric is possible in 100% of cases, it is possible to have many brains, but one hand is fundamental. In the case where you are a good surgeon, good person, and after that a good surgeon, there, Marco, the advantage of a robotic is the diva disappear. The status of the diva disappear is fantastic. It's fantastic. It's my opinion.
Thank you very much. We run out of time already. We're pretty late. I want to thank all of you for participating, our speakers, our discussants, experts, dear Juan. And we need to close this webinar. I wish to all our participants a Merry Christmas and a good start in the new year. And maybe for Christmas, somebody receives a robot somewhere.
Yeah, absolutely.
Thank you very much.
Merry Christmas.
Take care.
Merry Christmas.
Merry Christmas,
Bye-bye,
everyone.
Joanna.
Merry Christmas.
Bye.